Hello, and welcome to the Orthodontic Products Podcast. I'm your host, Allison Warner. In this episode, we explore what can be a critical yet often underperformed aspect of orthodontic care, airway-friendly orthodontics, and its role in treating upper airway obstruction and sleep-disordered breathing. We're going to talk about how the orthodontist role can go beyond providing a beautiful smile and really impact a patient's overall health and life expectancy. My guest is Dr. Tito Norris, an orthodontist who has made the treatment of upper airway obstruction and sleep-disordered breathing a part of his practice. You might have seen his three-part series in recent issues of Orthodontic Products and online, where he talks about integrating this aspect of care into your practice and shares clinical cases. Dr. Norris is in private practice in San Antonio and lectures both nationally and internationally. He also holds several patents and trademarks and is the inventor of the Norris passive self-ligating bracket system. We'll discuss how orthodontists can recognize airway-related problems, utilize CBCT imaging and sleep questionnaires, and collaborate with ENT and sleep specialists for comprehensive patient care. Plus, Dr. Norris will share treatment approaches, including the role of the MARPE in treatment, and recommend resources to help you get started and go deeper with this treatment modality. Here's our conversation. Dr. Norris, thank you for joining me.
It's my pleasure, Allison.
Great. So let's get started. What inspired you to incorporate airway-friendly orthodontics and sleep-disordered breathing treatment into your practice?
Well, it's actually been a goal of mine for many years, honestly. The struggle that I had was actually finding the supportive team to work with. And in particular, the element of that team that was lacking was an ENT who really got it, right? Who really understood that, tonsils, yes, they might eventually shrink, but by that time the damage is done. And, if a kid can't breathe, he's really suffering and he's not getting great sleep. It's going to affect their performance at school, their performance on the soccer field. What you learn that day, it doesn't get uploaded to the hard drive, and so it affects them, neurocognitively in terms of their development. And so finally, we started educating some ENTs, and we got a couple of new ENTs in town, and so that has really changed things dramatically. And so we've kind of been working hand in hand now with some I'm going to say enlightened ENTs who get it and who are willing to take our referrals and actually do something about it, and not just treat patients based on what insurance will pay or will not pay and so forth. It was just quite frankly very frustrating. I mean, we've been doing some airway friendly treatments for many years. However, also I have to say that simply technology has changed, right? And we've got tools that are available today that we didn't have before. TADs, MARPEs, those kinds of things. So those have all made big changes. And quite frankly, I was influenced by Dr. Jeff Rouse, who is a prosthodontist, and he's actually here in San Antonio. He speaks at the Spear Center, and I treated his son. And he's a very, Dr. Rouse is a very airway-centric prosthodontist, and who has a absolutely astounding command of the literature in this area. And he has really enlightened me. It's just a number of things that we can do to help patients in this regard.
Okay. So what are the most common signs and symptoms you look for when evaluating an adolescent patient and then an adult patient? Because I know you also do treat adults for airway obstruction or sleep disordered breathing.
We do. Roughly almost half our patients are adults. But whether it's child or adult, I mean, we're looking for things such as a high caries rate. That can occur due to mouth breathing often. Open bites. Anterior open bite, lateral open bites, which is often an indication of a tongue, position that's not right. And then we ask the question, well, why is the tongue position not right? Right? It's very often they're tongue tied, or maybe, which they can lead to microglossia. Maybe they're pushing the tongue forward because they've got large tonsils. That's often the case. And they're just trying to get more air. And so a lot of your open bite cases are actually airway cases. Things such as anterior spacing, patients who have a narrow maxilla or B-shaped palate, posterior cross bites, high mandibular plane angle, short upper lip can be an indication that the patient has nasal obstruction, and you get some atrophy of the levator labii muscles in the upper lip. And so the upper lip tends to shorten. It has a very specific pattern. It's actually
Mm.
short at the philtrum, but not so much at the commissure.
Okay.
So you get this sort of gull wing looking shape to
Oh,
the upper lip, which
okay.
also often is like pathognomonic for
Mm-hmm.
patients who've got nasal obstruction and mouth breathing. And they were also looking such as vertical maxillary excess (VME), and then even patients who have like anterior wear on their teeth, because these patients will function out here in protrusion because they're
Mm-hmm.
trying to get more air,
Mm-hmm.
and especially during parafunctional times, maybe nocturnal bruxism, but they're doing that in protrusion, and so you'll see this anterior wear pattern. And so all of these things are essentially canaries in the coal mine
Right.
that we as dentists and orthodontists can see these things and can recognize these things and get the patient's early treatment before some of the systemic issues start to pop up. And those systemic things are what an ENT may or may not recognize. But once again, if you have your radar up, you can start asking the appropriate questions and correlate some of these dental signs and symptoms with some of the systemic ones.
Yeah. So talk to me about how sleep questionnaires, like, so I know in your practice you use the Chervin Pediatric Sleep Questionnaire or CPSQ and then SNOT 22
That's
to
correct.
help for adults and help in identifying potential airway issues. So talk to me about those questionnaires and why those were right for your practice.
Sure. Well, first of all, these are there's a lot of different questionnaires out there.
Yeah.
These were the two most validated instruments that were
Hmm.
out there, and by that, what I mean is that in multiple studies, they've been shown to have a very high correlation with symptoms, and so not just symptoms, but the questionnaire has a high correlation to the actual issues. Okay, that's what I'm saying. And this has been tested this over and over again, multiple times in the both sleep medicine and ENT literature. And so, for that reason, number one, they're the most reliable, the most tested tests out there. Okay, so that was reason number one. And then reason number two, it's just a fairly easy thing to do as part of your normal medical history to go ahead and just have them fill out one more little form there
Yeah.
and screen everybody. And it's amazingly surprising how many times you'll pick up things that you might not have picked up just simply because you asked the question,
Yeah.
right?
Okay. So how has CBCT imaging changed the way you assess and diagnose airway issues in orthodontic patients? Because I know that's a part of your diagnostic
Absolutely,
protocol.
absolutely. And quite frankly, I just, wow. I mean, I've been doing this for 30 years, and
Yeah.
I know that I practiced without a CBCT for many years, but
Yeah.
today I just can't even imagine going
Mm,
back.
okay.
'Cause I think I've been using CBCT for probably about half my practice, like probably about the
Okay.
past 15 years I've had
Okay.
one. Um, but today we just use it so much, not just for looking at roots and but we're looking at width of jawbones, and we're
Mhm.
looking at deviated septa. We're looking at things like, root angulations, upper jaw versus the lower jaw bone. We can do a minimal axial airway analysis, and that's another tool that we combine with our questionnaire with
Okay.
symptoms. So there's so many things that we get from CBCT, but you have to kind of take that with a little bit of grain of salt because it's
Hmm.
not always it doesn't there's not always a direct correlation is what I'm saying, because you've
Okay.
got a static image of a dynamic process, right?
Hmm.
And even if the CBCT is taken well with a patient in the proper posture and swallowing and all these kinds of things, there is still very few people I know who sleep standing up,
Right.
right?
Yeah.
And so we don't have, number one, we don't have a CBCT that takes the records in the same position that we're sleeping in, and number two, it's a static image, and we all know that breathing is a dynamic process. So that those right now today are the two major limitations of company.
Okay. So, what specific anatomical structures do you examine to kind of determine if a patient has an airway obstruction?
Yeah. Well, I mean, gosh, there's a lot of things. Okay, one of the things though, we're looking at the maxillary position, and we're seeing where the maxillary incisor falls in relationship to vertical from soft tissue nasion. Okay, so that's kind of like the first place that we look. Okay, where is that maxilla?
Yeah.
And if it's back, it's retrognathic, and then we start to kind of spidey sense starts to pop up there and see, okay, well, there's a very maxillary deficient, and very often it's the thing. And we look at a Ceph, we look and see, hey, do they have swollen adenoids? We're looking, just even at the airway on a Ceph, you can even see the tonsils there. We're going to the CBCT, we're checking on those same structures, but now we can look at those things in 3D. We're looking in the mouth, we're looking for posterior cross bites. We're looking for, like I said, a narrow maxilla. We're looking for retrognathic, either maxilla or mandible or both. And, things such as wear on the teeth and all the things that we just kind of talked about, narrow, V-shaped maxilla, high mandibular angle, short upper lips. All of those things are signs and symptoms of airway issues. Yeah.
Okay. All right. So we've talked about kind of the evaluation and diagnostic. So let's talk about treatment approaches. How does maxillary? Yeah. Go ahead.
Before we go there, we do have within our practice, we actually have some home sleep studies that
I was going to ask you about that
to patients. So these are in our practice, we use the WatchPat, which is a very robust machine. In fact, it is the same machine that the VA hospitals all over the United States use to diagnose sleep apnea on their patients. Now, because I'm not a sleep physician, I can't make a sleep apnea diagnosis, but I can certainly read a WatchPat legally and tell the patient that, there are some signs that you might have sleep apnea, and therefore, and that usually gets their attention. And I just don't want there to be any barriers for them, right? So we give this to them complimentary. They check it out like a library book, gives a credit card, and we take care of, as a loss leader, we kind of take care of the disposables. It's $50 or something like that. So that's another piece to the puzzle diagnostically that really helps us get the attention of the patient. Now, that's the WatchPat is it's great for adults, but it's not so great for kids. But so on kids, we can just send them home with a simple pulse ox. And we can look at some things like that. And if we really have an eye index of suspicion, we can, of course, try to get them seen by a sleep lab and get that sleep study done.
Okay. So once you have that data, are you then sending them out to a sleep physician or an ENT, or how are you approaching it from there before treatment?
Yes. Okay. And so let's just take for instance, I saw a patient the other day who, came to me for malocclusion, and I suspected that he had sleep apnea, and his wife was kind of like, well, maybe, and he was like, well, I don't know. And so we sent him home with a home sleep test, and it came back very positive as severe sleep apnea. And so, I'm like, okay, listen, run, don't walk, and let's go get you into the care of a sleep physician, and get a sleep test. You'll get a CPAP machine, and if you love it, fantastic. And if you don't love it, come back and see me, because you would be a candidate for MMA, maxillary mandibular advancement. Yeah. Because somebody who's got his AHI was 52, right? So 52 times an hour, he stops breathing.
Okay. Yeah.
So basically every minute he stops breathing.
Yeah.
Right. Yeah. So that's pretty bad.
Okay, so once they do come back to you, let's talk about treatment approaches.
Yep.
So what are the key options you're looking at let's start with adolescent patients. What are you doing there?
Sure. So on adolescent patients, basically we're making sure that they got, a clear airway in terms of a patent nasal airway. And so the ENT is helping us with that. And we're also just doing expansion. Because as we know that the roof of the mouth is the floor of the nose. So when you expand, you're not only creating more intraoral volume, but you're also increasing your nasal breathing volume.
Mhm.
And then you get an exponential benefit due to Bernoulli's principle. So if you expand, a 1x, you get like a 3x
Right.
improvement in nasal breathing. Okay.
Mhm.
Um, and so that's the main thing. And now the other aspect of it is the expansion on anybody is going to by creating a larger oral cavity.
Mhm.
Think about the tongue as like a water balloon. Okay. So
Mhm.
part of that tongue has to exist in the mouth. And then the root or base of the tongue actually exists, down in the pharynx and
Mhm.
the breathing tube.
Yeah.
Okay. So imagine that water balloon, and if you squeeze on that pharyngeal part and make it smaller, or in other words, if you make the oral cavity bigger and that grows, well, then the water is going to go into there, right? So it
Mhm.
makes the pharyngeal aspect smaller. Conversely, if you have a small oral cavity, then more of that tongue has to live in the pharynx. So simply by expanding and having a larger oral cavity, more of the tongue can live in the oral cavity,
Mhm.
less of the tongue has to live in the pharynx, and
Mm.
that opens up the airway.
Yeah.
Right?
Okay. And then for adults, what are you opting for there?
Yeah, and so with adults, it really kind of depends on a number of factors. First of
Mhm.
all, how severe are they? Right?
Mhm.
Are we talking mild, moderate, or severe? Personally, I'm not a big fan of oral mandibular advancement appliances because they
Okay.
all change your occlusion. And
Mhm.
unless you're class two, you know, it's not great. And then you're
Mhm.
married to an appliance, right, for the rest of your life.
Okay.
So I'd much rather fix the physiology, okay, fix the structures. So what does that look like? Well, in many cases, that looks like some expansion. So sometimes that's dentoalveolar expansion,
Mhm.
and sometimes that means that we got to add some bone using a procedure called SFOT or
Yeah.
PAOO, or also called Wilcodonics, right? To
Mhm.
simply add some bone.
Yeah.
And then sometimes we do a MARPE, right? A mini-implant assisted rapid palatal expansion to broaden that maxilla. And we now know that we can do this at any age. You just have to engineer the MARPE in
Mhm.
such a way that to get success. And so that's basically expansion of the oral cavity is definitely a strategy.
Mhm.
And if they're severe, well, then maybe we do that in addition to doing mandibular advancement or in doing
Yeah.
a bimaxillary advancement.
Mhm.
So outward and forward, that's the whole key, is to
Yeah.
opening up the airway.
Yeah. Are there advantages to treating an adolescence rather than adulthood?
Well, sure. And the biggest advantage is, I mean, this is a progressive disease,
Mhm.
right? So imagine that you had cancer. Like, when would you rather catch it? Like
Yeah.
early on
Mhm.
or late? Well,
Mhm.
I mean,
Mhm.
early on.
Yeah.
So, children shouldn't snore.
Mhm.
And so if you have a child that's snoring, that's an indication that they've got some form of sleep disorder breathing.
Mhm.
So it's much better to catch that, in the early light snoring stages rather than waiting until they develop, full on sleep apnea.
Mhm. I know in part 3 of your article, you shared how you had one adult patient who didn't want to take a surgical approach and another patient who opted for it. Can you talk to me about how you talk to patients
Sure.
about those options and talk and
Yeah.
get them where they need to be?
Sounds great. Well, so in both patients had received 4 premolar extractions when they were teenagers. Okay.
Mhm.
And both of those patients developed sleep apnea, later in life,
Okay.
typically in their 40s or in their
Mhm.
50s. And so in both these cases, I gave them 2 options. I said, listen, I can restore your premolars. In other words, we can open up the spaces for those
Mm.
premolars
Okay.
and give you back that space and give you back that oral cavity volume, if you will.
Mhm.
And it might help with the sleep. I mean, it's going to help, okay, but I can't tell you that it's going to cure your sleep apnea,
Yeah.
right? The difference there is that it's a lot of orthodontics, and you're
Mhm.
probably going to have to go through 1 or 2 rounds of SFOT and add bone and so
Mhm.
forth, and you're going to be in treatment for quite some time,
Mhm.
um, with without a guaranteed result. Okay, or we can take the other option, which is do the MMA. And we work with some very talented surgeons. And, in 2 hours, they can do what takes us 2 years.
Hmm.
Right. And they can bring the jawbones forward. And essentially, I mean, if you look at the literature, it's over 90% cure rate.
Okay.
And we've probably done, I mean, dozens and dozens of these patients. And I can tell you that I don't think I've had a single one who it hasn't, completely cured their sleep apnea.
Yeah.
So, and the statistically, it is the gold standard
Okay.
for curing sleep apnea.
Okay. So talk to me about, as the owner of a practice, kind of from the practice management side, what does it take to implement this type of care into your practice?
Well, I mean, you've got to be, of course, open-minded about it.
Hmm.
And I look at myself as not just a tooth mechanic, right?
Hmm.
I'm looking at more of a holistic approach to orthodontics. And for me, it's a much more rewarding way to practice. And so what does that mean? Well, yeah, I mean, it means you've got to invest a little more time in a new patient examination,
Hmm.
right? You've got to invest in, the basically developing. I mean, you don't have to develop these forms; they're already there, right?
Yeah.
But somebody has to brand it, put your name on it. You have to put it part of your medical history thing. I mean,
Yeah.
so it's the questionnaire, the CBCT, the exam, right? Those are the big things that go into the
Yeah.
practice. And in terms of what we're doing, day to day, that hasn't changed all that much, except
Okay.
that now we've got the MARPE,
Mm.
which we didn't have 10 years ago.
Mm.
And so that has probably been the biggest change in my practice is that, we use a MARPE on teens. Like if they've got permanent dentition, they're getting a MARPE because the literature
Okay.
is very clear on this. It's
Hmm.
very clear that we get superior skeletal expansion and much less dental tipping.
Hmm.
In fact, there's even literature coming out now that is showing that a MARPE has less bone loss around the molars
Mm.
than your traditional tooth-borne expanders in the teen
Yeah.
years, your Haas or your, Hyrax and those kinds of things.
Yeah.
So there's a great study out of Canada. There's another one out of Korea.
Hmm.
So these are the two of the early studies. So I mean, to me, the literature is definitely pointing in that direction, and we just want to stay, ahead of the curve and be on the leading edge here. And the thing is, if you've got an airway issue, which is we all do in our practice, right?
Hmm.
And if
Yeah.
we know that a MARPE gives us a superior bony change with less dental tipping, then why don't we use what's best for the patient, right? And yes, it was a challenge kind of working out all the little details to get the systems involved. But
Hmm.
but now on a standard MSE MARPE in our practice takes 90 seconds of doctor time.
Oh, okay.
Okay. It takes me
Okay.
a minute and a half of
Hmm.
chair time to deliver that appliance.
Okay.
So it's not a practice disruptor anymore.
Yeah.
And it's just, you just have to make that commitment to, this is, I feel like this is the right thing to do.
Yeah.
I'm serving my patient the best way. And so we develop those systems to get it done in an efficient
Yeah.
manner.
You talked before about how you collaborate with an ENT. Talk to me about developing those relationships with ENT specialists and sleep physicians, because that is part of this patient's care team.
Yeah, it really is. And honestly, a lot of it is, us educating them.
Mm.
Okay. As to the things that we see, the fact that we get to like I said before, the little canary in the coal mine signs and symptoms that we have that actually show up even before some of the systemic symptoms show up, and just letting them know about that. And that's just, sometimes it's easy as like a lunch and learn, going in and talking to them and sharing those types of things. And sometimes they're receptive and sometimes they're not. It's like, oh, sometimes they put on their doctor hat and what's this dentist going to be teaching me about stuff,
Yeah.
right? But I think once again we have the literature on our side, and it's very clear that that this is the right thing to do. And I think that that's very helpful, as many physicians will respond, especially if it's in a medical journal like Sleep or
Yeah.
one of these other medical journals. They'll be much more receptive to that. Unfortunately, Guilleminault is kind of like the father of sleep medicine, if you will, at Stanford, and he did a great job of getting things published in medical journals. So you can hang your hat on a lot of those publications. Yeah.
Are there any resources or trainings that you recommend for orthodontists who are interested in kind of implementing this into their clinical workflow?
Absolutely. Well, one of the best courses that I've taken is actually from Ilya Lipkin, and Ilya Lipkin is in New Jersey,
Hmm.
and he probably has the most experience of anyone in terms of custom MARPEs on adults.
Okay.
And I think he's just a wealth of information. Plus, he's just a super generous guy who
Hmm.
shares openly. And, I had already done over 500 MARPEs when I took his course, and I
Hmm.
still learned a lot about some of the little nuances that he's
Yeah.
developed and uses. I thought it was a fantastic course. And so I give kudos to him, not only for giving such a great course, but also just for being so humble and
Hmm.
generous. I think our profession really is in debt to him. Audrey Yoon is another one. If you get a chance to see her speak, I think she's really got a lot to share. Rebecca Bacall, she gives a course at least once a year in Seattle. That's
Hmm.
another amazing course to take. And then Mariana Evans would be the other one. So I think these four people are kind of leading our
Hmm.
profession in the right direction. And so I think any one of those four would be great.
Okay. Well, to our listeners, we'll include links to those practitioners in our show notes. So look out for that.
Um, well,
Yeah.
and truthfully, I actually give an in-house course a couple times a
Ah,
year,
okay. All
and
right.
so Norris, so maybe you can add one
I
more in
will
there.
add yours.
Yeah,
Absolutely. Absolutely.
and we do a hands-on thing, live patient demo with delivering a MARPE and so forth. So
Oh,
it's
cool.
yeah,
Excellent.
it's good stuff.
Okay. So, last question. What's kind of your takeaway advice to orthodontists who are looking to integrate airway assessments and treatment into their practice?
It takes a commitment, right? It takes a commitment from not only you but your team. It takes buy-in, and and sometimes, I mean, you can't do it yourself. You've got to have the team's support, and fortunately, we do because you've got to have administrative buy-in, you got to have clinical buy-in, and so sometimes it means going with those people to one of these courses or to the AAO or listening online to something like that to really get them on board. And once they do, then it's so rewarding to every single day to be talking with patients and parents who literally just want to give you a hug
Hmm.
because yeah, you've changed my life, or what have you done with my children? They're completely blossomed. They're so much better, and to also just kind of note, statistically speaking, that if you take someone who's got sleep apnea
Hmm.
and you can fix them, right? Well, you've added 10 years to their life.
Yeah.
Okay,
Yep.
statistically speaking, you've given them 10 years. I mean, that's what a gift,
Hmm.
right? I mean, there's nothing more valuable than 10 years more.
Yeah. Absolutely.
It's really amazing. I mean, I used to tell my team like, "Hey, listen, don't worry about it. We're not saving lives. We're just straightening teeth." And I can't say that
Mm.
anymore.
No?
We're really extending lives today. So
Yeah.
it's for me, it's such a more satisfying way to practice.
Hmm.
And a lot of my friends who have been doing it for 30 years, like me, a lot
Hmm.
of them are kind of ready to sail out into the sunset.
Yeah.
And I'm just so energized and invigorated by what I've learned over the last 10 years, and
Hmm.
it's just a fantastic way to practice, a holistic way to practice, and I'm more than just beautiful smiles, right? It's health,
Yeah.
really, being a health
Absolutely.
practitioner.
Absolutely. Yeah. Well, thank you, Dr. Norris. I so appreciate your time and your expertise on this topic.
Well, thank you so much for the opportunities to share what I've learned. I've stood on the shoulders of some wonderful people and learned a lot from them. And and through Orthodontic Products, you guys have allowed me to share a lot of what I've learned through this three-part article series on sleep disordered breathing.
Great. Well, thank you again. As always, thank you for joining us. Be sure to subscribe to the Orthodontic Products Podcast to keep up with the latest episodes, and be sure to check out orthodonticproductsonline.com to keep up with the latest industry news. Until next time, take care.